The diencephalon, and to return a little to the embryology of it with these diagrams that show the development of the diencephalon as seen in a mid-sagittal view, gestational age along the x-axis and the body length, crown rump or crown heel along the y-axis. In the very early embryo, we've shown here the continuation of sulcus limitans up into the ventral sulcus dividing hypothalamus from thalamus. And then, as the next stage develops, dorsal and ventral thalamus become separated by the sulcus medius, and then the ventral thalamus begins to move away as the dorsal thalamus gets bigger. And then over in this view, it becomes bigger still, and the ventral thalamus has essentially disappeared from the surface, so that the hypothalamic sulcus separates the dorsal thalamus from the hypothalamus. Meanwhile, the epithalamus, of course, has been present all along as the roof of the third ventricle. And then in the top half of this view, we have three cross sections through the thalamus to show the dorsal, medial, and ventral portions as the center median nucleus develops, and the topographic arrangement of dorsal, medial, lateral subdivisions of thalamic nuclei continues. The next chart has to do with the development of the eye, the visual system, which is a protrusion from the ventral anterior part of the third ventricle as the ventricle meets the ectoderm and induces the lens placode. The optic cup invaginates, so that we have an inner and an outer layer of retinal cells, the outer layer becoming the pigment layer, the inner layer becoming the three laminae of cells. As the development continues, we have the anterior chamber being induced, and the cornea and eyelids outside of that. So the eventual obliteration of the ventricular system leads to a solid optic nerve going back to the diencephalon. So in a sagittal view, we can pick that up. Forward over here. We go back to the sagittal view of the third ventricle with the anterocomissure, the optic chiasm here, and the analysis, back here, nuclear stalk, and so on. The optic chiasm, of course, as it proves out, originally is shown as the hollow optic ventricle. The retina, with its three layers of cells, having a pigment layer in back, so that when the light comes through from the lens and cornea, comes through and hits the pigment layer, it then bounces back onto the rods and cones. I'll exaggerate here as rods and cones. And they then activate the second neuron, bipolar cell, which then projects onto the third cell, the ganglion cell, which sends its axon over the surface of the retina and back into the optic nerve. And then, depending on whether it comes from the nasal retina or the temporal retina, crosses not in the chiasm and continues on back in the optic tract, essentially making the visual system an almost pure horizontally oriented system with connections that we've mentioned before. I put some more landmarks in. That was the floor of the aqueduct. Here's the roof of the aqueduct. You know, flooring down, so you get to the brand in place. Ponds, patella, roof, ocean commissure, cuticuli, cerebellum. The first system that we talked about was the pretectal area. The tectum and the pretectal area receives fibers which are going to subserve the light reflex and will make connections around the aqueduct to the Eddinger-Westphal nucleus, and back out to the third nerve, to the ciliary ganglion, and postganglionics to the intraocular muscles. Your ciliary ganglions out here, and the third thing is there. So, this we talked about back in the retinotectal fibers come into the superficial layers of the superior colliculus and are laminated superior colliculus and makes connections down through the deep layers of the superior colliculus and connections, among others, to tectospinal and to tectothymic. So that we have that system we talked about just the other day. The system I'd like to introduce today, I introduced it yesterday, is a continuation of this retino-pretectal, retinotectal, and retino-lateral geniculate for conscious vision. And this projection is going to go back to the occipital cortex, area 17. That's visual radiation. Now this lateral geniculate body is probably best seen, I've stretched out here, separated a little, but it's best seen perhaps in a horizontal section of the midbrain. And now, since there are no neuroradiologists present, I can try to draw the midbrain upside down. And that I'm not good at. Aqueduct, periaqueductal gray, colliculus, intraocular fossa, colliculus. I don't know how it's like if I set up. A substantia nigra, and peduncle. And just behind the peduncle, we're going to find lateral geniculate nucleus with its projections coming back to area 17 and its afferents coming in from the chiasm tract around the peduncle optic nerve, optic chiasm, optic tract. Almost a straight shot back to lateral geniculate, and just drops from this into the pretectal area and into the cliculus. So the whole system is almost in horizontal plane. Almost get the whole thing in a straight horizontal view. As I indicated yesterday, though, we have a slight complication, and that is that the forebrain has been developing with its temporal lobe swinging around, and so this visual radiation gets progressively swung around, so we have a so-called temporal detour. Meyer and Archambault, as the temporal lobe swings around. Now, that's fairly easy to see once you see portions of the internal capsule. The internal capsule is one of the major landmarks in the forebrain. And that's best seen at a slightly higher level from the midbrain. In a horizontal view, if we come back to the thalamus, we saw yesterday, it's sort of a sloppy egg-shaped mass here with its medial, interlaminar, and lateral portions, with the third ventricle here. In front we have the head of the caudate. So we have lateral ventricle up here, and a septum pellucidum coming down, 2 leaves, and the fornix on either side. And of course up top here, to close this off, we have the corpus callosum. You put a wall of the third ventricle in here on the other side. So we have Monroe's foramen. Between the third and lateral ventricles, bounded by the columns of the fornix as they sweep around from behind, forward, down, and into the hypothalamus. Now the internal capsule is then bounded by the caudate head and thalamus. And since the caudate is coming back here, we're going to have another piece of caudate here, tail, with the body in between up above here, this more superior dorsal view. And then laterally, the basal ganglia with the globus pallidus and putamen in there. And these I'm giving you now just for gross landmarks. But the internal capsule, mass of white matter between these 1, 2, 3, 4 structures, has an anterior limb, CIA, capsula interna anterior, and a posterior limb, CIP, capsula interna and posterior, and a genu, capsula genu, in between, where the bend, this knee-like bend occurs, which you only see in a horizontal section. These are essentially fibers running at right angles to the board that have been deformed by the deep cerebral nuclei laterally and medially. And why does the GNU occur here? Well, there's nothing here to push it. The head of the caudate is here pushing it laterally. The thalamus here pushing it laterally. But at the GNU, we have Monroe's frame, and there's essentially nothing there between the ventricular system and the capsule. That's one reason. The second reason is that the globus pallidus, coming from the lateral side, pushing it medially. And so we have these two medial lateral factors that meet right at the Monroe's foramen and serve to push the GNU medially. If we were to make a cross-section, coronal section at any level here, we're not going to see anything as dramatic as this. There's not going to be any bend. The fibers are going to be straight down. They're going to come closer to the ventricle here at the GNU than they will back here posteriorly or anterior. But otherwise, they're essentially the same descending or ascending, cortical thalamic, cortical striatal, cortical spinal, and so on, or down, or thalamocortical and up. So any problems at this point on sort of the gross orientation of, first of all, the visual system, and secondly, the internal capsule. I've left out a piece of the story, and that is, where does this temporal detour fit in relation to the rest of the internal capsule? Come to that next more. Any other questions, comments, problems? Three-dimensional anatomy. Well then, having run out of space, let me draw it over here. We need a coronal view of the brain. So we'll put in the epithalamic stria, thalamus, hypothalamus, or roof. Continue the thalamus around, the hypothalamus down and over. Put in a piece of caudate body. Cut more superiorly than the previous horizontal section up through here. Put in a the color scheme is more or less the same. We'll put in the putamen, globus pallidus, like so, and we have to pick up the tail of the caudate down here in the temporal lobe. So we've kept the caudate body and the caudate tail in continuity as we come from the head, body, tail, and continue the tail on temporal spiral. And now I need to put in the lateral geniculate, which is going to be at a slightly more posterior level than I've drawn here. And I might just as well put the medial geniculate next to it. And now for orientation, I better put in some cortex that we have some insular cortex out here, temporal lobe over here, frontal lobe over here, and if you like, corpusculum, and cingulate gyrus, frontal lobe, and so on around it that way. Now, if you were to build the auditory system, which is the easiest, I think, to visualize, you go from medial geniculate straight through the temporal lobe. In what is now the sublenticular limb of the internal capsule. It's the same kind of fibers that we were talking about here, coming at right angles to the board, thalamocortical. Same thalamocortical. Auditory radiation, just going straight laterally out the temporal lobe. The only way to get there is to go beneath the lentiform nucleus containing the corpus callosum. Hard to show in this view. Put the medial geniculate down to the lower level, and the fibers come straight out the temporal lobe. Visual radiation is going to do almost exactly the same thing as far as the temporal detour is concerned. These are going to go out over the temporal horn of the ventricle, coming towards us and going back in the white matter. First, they're running in the sublenticular region of the internal capsule. And then they're going to be running here back, here forward. So this is going to be sublenticular. And this is going to be retrolenticular behind. So all we've done is to take thalamocortical fiber, in this case, geniculocalcarine, visual radiation, and distort them by having the temporal lobe come forward and drag them forward underneath the lentiform nucleus. Put the lentiform nucleus on top and push them down and back, so that the others that are going to go straight back in the parietal lobe, white matter, are going to be going away from us on the other side of the board here, behind the lentiform nucleus. So it's all one sheet of fibers. Pushed laterally by the thalamus, pushed backwards by the lentiform nucleus, pressed by lentiform nucleus, pulled forward by temporal lobe. So it's a sheet of fibers that is deformed. Deformed, but in a way that I hope is obvious, considering the other structures are there.
Are you drawing a sublenticular pathway out, swim around, or straight across the points?
Sorry, which one?
Sublenticular.
Yeah, I've drawn this away from us and forward, down into the temporal lobe, which is pull them forward, but there's still essentially geniculocalcarine going lateral geniculate back to the visual cortex. And really nothing more mysterious than that. They just happen to have, once you remember that the temporal lobe is inferior to the parietal lobe, they happen to have contralateral upper visual field fibers. So a temporal lobe lesion characteristic produces a contralateral upper quadrant synopsis. So since I've left out the lateral ventricle here, I've got the tail of the caudate in the roof. We've got the hippocampus on the floor, the dentate gyrus, and the fornix accumulating over medially here. We've got the perihippocampus coming around, so I'm just going to miss the temporal lobe here. But here we have the choroidal fissure, blood vessels having grown in, the stalk of the choroid plexus, in the most medial part of the temporal horn. The fornix in the floor, the caudate tail in the roof, and immediately next to it, the geniculate, and the fibers come out into the temporal lobe, and so that's how they get to be lateral. They're above and lateral to the temporal horn. Which was a little exercise I asked you to think about it. How they get from diencephalon out into telencephalon, very lateral to the lateral ventricle. About the only way to go once you've given the position of the temporal stem and the lentiform nucleus. Temporal lobe, lentiform nucleus, and that puts them between caudate putamen, just as the rest of the posterior limb is between caudate putamen up here. Caudate putamen caudate was one nucleus. Right? It's just divided by fibers and cut off pieces of it. Now, having gotten the visual radiation lateral to the lateral ventricle, and you can visualize the lateral ventricle temporal lobe coming back behind the thalamus up to the body of the ventricle. Trigone behind the wall, much the one going away from us. The retrolenticular limb is going to come out in what relationship to the trigone? Medial, lateral, superior, inferior, anterior, posterior.
What's the trigone?
Trigone is where the temporal horn and occipital horn meet the body. So we have these three pieces: the frontal extension to the body of the ventricle, the temporal extension, and both of those moving forward. We have occipital, temporal, frontal. And so here's the body, here's trigone. There's the three major pieces of lateral view meet. So as we're coming from the temporal horn back into our occipital horn, and forward into the frontal horn, of which the body up here is halfway. Where is this visual radiation going to run in relation to the tricone? It will be lateral, that's correct. There is lateral here. So it's going to stay lateral to the temporal horn, lateral to occipital horn. But in this portion of the tricone, where is it? It has to be anterior to it. I mean, the diencephalon is sitting here, so it's going to come up between diencephalon and telencephalon. So it's going to be coming over, but this over is in sort of a horizontal plane, whereas the other over is in a frontal plane. So it's running in this retrolenticular part of the internal capsule between diencephalon and telencephalon. And comes to fly on the lateral surface of the ventricle, whether it's temporal, tricone, occipital. Now, Steve, if you make a coronal section through the occipital horn, same plane here. We've got the occipital horn, something like that. Calvary fissure with the cortex above and below. So we'll make gray matter do something like that. This would be the midline over here, the Calvary fissure. Pushing in to the occipital horn. So here we've got Gennari's line. Identifying area 17. And now laterally, we've got this heavy layer of white matter. Fibers that are running at right angles to this cord, horizontally back towards the occipital pole. And so how do they get, they're not lateral, how do they get medial? I'm deliberately trying to make it more of a problem than it is. Which? Because it really isn't a problem. Fibers just come around the ventricle, over the lobe. So the temporal fibers and the parietal fibers are running in visual radiation. Temporal and parietal, as a sheet of continuous fibers around the ventricular system, just peel off around the ventricle and come into the superior or inferior calvary cortex. And so what may at first look like a difficult problem of having visual cortex medial, visual radiation lateral, coming from a very deep structure, the lateral geniculate, or the diencephalon, really turns out to be a fairly simple thalamocortical projection, distorted by temporal, distorted by parietal, so you get a broad sheet in this coronal plane, temporal, parietal, distorted by basal ganglia, pushing in from the side, but going almost as straight as you can from diencephalon to telencephalon. Anyway, I hope that simplifies it. It's another one of these little anatomical problems. It took me years to see how they could possibly relate that way. So any problems on visual radiation, on visual system in general? The easiest visual field syndromes can be seen by, say, cutting an optic nerve, taking out an eye, making that eye blind. Or cutting the optic chiasm as by a pituitary tumor or meningioma, suprasellar, craniopharyngioma, and producing half blindness related to these crossing fibers, which are coming from the most medial portions of retina, receiving from the most lateral portions of visual field. Fibers go through the light rays go through the lens, and so it has a bitemporal, which is lateral parts, temporal field, bitemporal in the optic. Or if you transect the optic tract, you get the far side of each visual field. So it's a contralateral half blindness in the optic. Any problems? Now one can look microscopically at the lateral geniculate here and tell whether the lesion is an optic nerve or tract or cortex. The lateral geniculate has 6 layers. So this is layer 1, layer 2, layer 3, 4, layer 5, and layer 6 cells. This the geniculate on back is uncrossed. So all 6 layers are going to go back to occipital cortex. And so if you were to cut out the occipital cortex on one side, all 6 layers would show changes. And the cells undergo chromatolysis, swell, and then recover. So one could see that kind of change as a retrograde effect. It goes even further than that. In the visual system of an odd one, these cells will atrophy. And worse than that, they say, the atrophy will go through the synapse back to the retina. So one has a retrograde transsynaptic atrophy, visual cortex, all the way through the geniculate to the retina. Really slow process, taking years maybe, but unique, as far as I know, to the visual system. You do the reverse. Take out an eye, and what you see is a different pattern. The ipsilateral eye projects 2 layers, 2, 3, 5. This is, though, you can remember, 1, 3, and 5, you make them see by 1. And you'll see these layers atrophy. I should say that layers 1 and 2 are large cells. All the others are quite uniform, medium-sized cells. And so when one sees an atrophy of layers 3 and 5, these become small, atrophic, and so does layer 2. And so instead of seeing a nice, normal laminar pattern, 2 large cells and 4 medium-sized cells, you now see large, small, small, medium, small, medium. It sort of stands out. We have a picture on the laser disc that will show that to you. Get to it. If you cut the optic tract, of course you diaphragm the whole nucleus, and the whole nucleus will not only the ipsilateral, but also the contralateral fibers, so the whole nucleus atrophies. It's worse than that. The atrophy proceeds through the nucleus. You've got the transsynaptic atrophy of the whole visual system. Again, it takes a long time and is a general exception. Specific exception of the general rule that atrophy stops at the synapse. So it's just a good thing that Cajal didn't start with the visual system. You may recall that Cajal mastered the Golgi technique, and Golgi said everything was connected to everything else. It was Cajal that described the synapse, the junction between the cells. And one cell would die, but stop at that point. Had he studied the visual system first, he would have seen that the whole thing would atrophy on through. That was not until the late 1890s. So the whole concept of single cells and synapses was unavailable before that. So, what more do we want to say about diencephalon? There's one more little piece of information that I keep forgetting. It goes back to the most primitive part of the development of the diencephalon, and that has to do with the mass intermediate. Which is a structure that is gray matter in the third ventricle, connecting the two right and left valve lines. That is a secondary development. Along about 12 weeks gestation, 2 walls of the diencephalon touch, fuse, cells mix, and you have the beginnings of the mass intermediate. Having fused and exchanged cells across the midline and fibers, it stays essentially gray matter, and is most easily visualized as part of the intralaminar group as they come near each other below the medial thalamus and expand up into the intralaminar complex. Having formed, it stays there until about age 20. Then it begins to atrophy. It atrophies twice as fast in men as in women. So that by 60 years of age, it's present in about 80% of women and about 6% of men. And I don't know of any clinical correlates to that. It's a curious secondary structure. It seems to always form. Something like the septum pellucidum and the cavity in it. A secondary structure that always forms and then involutes at its own pace. So what more do I know about diencephalon? Near the end of it. We've divided it embryologically with epithalamus, dorsal and ventral thalamus, and hypothalamus. We move the ventral thalamus out into the lateral reticular nucleus and zona incerta, and also incidentally in the large cell parts of the nucleus. So we had left the hypothalamic sulcus between thalamus and hypothalamus. We got rid of the epithalamus rather quickly as serving properly the attachment of the choric plexus to the roof of the third ventricle. And for a small mass of myelinated fibers coming from a large number of places in telencephalon and the olfactory region, going back to the bending nucleus. We spent a long time in the thalamus with a large number of separable functions. And then we finally came to the thalamus. There's three major divisions: medial, lateral, and intralaminar. And I promised you that we would consider the center median with the basal ganglia, other basal ganglia. And the anterior nucleus will pick up the immediate future as part of the limbic system. And I urged you to remember the lateral third of the thalamus with its ventral divisions. So you have VA, VL, and VP in relation to center median. And remember the two geniculus. So we have the major relay regions of thalamus concentrated in that ventrolateral complex. And since the thalamus is the main, actually the only way into the cortex, the thalamus specifically is a ventral lateral complex, serves to remind you of all the rest of the nervous system. Segmental association plates, cerebellar, tectal, and their way into the cerebral cortex. So any problems?
I don't think you mentioned von Willebrand's knee.
Which?
Von Willebrand's knee, the fibers that come through the chiasm. Luke.
Thank you. No, I didn't. chiasm doesn't really form with fibers going straight through. They take a variety of detours back into the tract where they cross, or up into the nerve where they cross. And so one has distortions of the fibers as they're crossing the chiasm. And one can have asymmetric pressure upon the chiasm. But one or another of these asymmetries can be compromised and have an additional field defect or selective quadrant, depending on just how the system fails. So you might not have a pure temporal hemianopsin, but you might have a unilateral quadrant hemianopsin, or almost any combination of one quadrant or another quadrant with a bitemporal or a homonymous defect. Any other problems? Well, today is Tuesday. No class tomorrow. Thursday morning,